What if we could stop the immune attack that destroys insulin-producing cells? Researchers have tried, but the answers are surprising and not what you might expect. Here is the paper itself. Today, management of type 1 diabetes relies on delivering insulin and monitoring glucose levels. Advanced pumps and continuous glucose monitors have reduced hypoglycemia, yet they cannot halt the autoimmune process that destroys beta cells. The disease remains progressive despite these tools. Small amounts of endogenous insulin, measured by C-peptide, are linked to fewer severe hypoglycemia episodes, lower daily insulin requirements, and better long-term outcomes. Observational studies show that even modest preservation of beta cell function translates into meaningful clinical benefits for patients. Biswas and colleagues asked whether the promising immunomodulatory drugs that protect beta cells also lead to better glycemic control. They noted a puzzling disconnect. Many trials showed preserved C-peptide, but no change in HbA1c. They also wanted to compare safety across different mechanisms, such as T-cell depletion versus regulatory T-cell enhancement. The authors performed a systematic review and meta-analysis of 19 randomized controlled trials, enrolling a total of 852 patients with newly diagnosed type 1 diabetes. They compared 3 immunomodulatory strategies: anti-CD3 antibodies teplizumab and otlixizumab, and low-dose interleukin-2 to placebo or standard care, focusing on beta cell function, glycemic control, insulin requirements, and safety. Primary outcomes included the stimulated C-peptide area under the curve, reflecting beta cell function, change in glycated hemoglobin as a measure of glycemic control, and daily insulin dose expressed as a standardized mean difference. The authors extracted means, standard deviations, and sample sizes, applying random effects models and Hardung-Knapp adjustments for robust inference. Across all trials, immunotherapy produced a modest but statistically significant improvement in C-peptide levels, with a pooled standardized mean difference of 0.221 and a p-value of 0.007. This indicates that treated patients retained more beta cell function than controls. The forest plot visualizes each study's effect on C-peptide, showing most estimates clustering around a small positive benefit. The overall pooled estimate of 0.221, with a confidence interval that does not cross 0, confirms a consistent modest preservation of beta cell function across diverse immunotherapies. When the same trials are examined for glycemic control, the pooled standardized mean difference for HbA1c is 0.03, with a confidence interval spanning negative to positive values. This indicates no meaningful improvement in blood sugar despite the beta cell preservation seen earlier. Insulin dose requirements showed a modest decline, with a pooled standardized mean difference of 0.26. The confidence interval crosses 0, suggesting that while some studies reported lower insulin needs, the overall effect is not robust and may diminish over time. Low-dose interleukin-2 stood out, producing a significant HbA1c reduction of 0.514, p equals 0.025, even though its effect on C-peptide was negligible, SMD equals 0.020, p equals 0.967. This paradox suggests metabolic benefits independent of beta cell preservation. The meta-analysis confirms that immunomodulatory drugs can modestly protect residual beta cells, but this does not translate into lower HbA1c for most agents. The exception of low-dose IL-2 hints at a separate metabolic mechanism that improves glucose control without affecting beta cell mass. Clinicians should therefore temper expectations of glycemic benefit from beta cell preservation alone. Safety analysis revealed a stark contrast. Agents that broadly deplete T cells, such as anti-CD3 antibodies, were associated with a 3.2-fold increase in serious adverse events compared with T-reg enhancement strategies like low-dose IL-2. Notably, all 5 deaths reported in the dataset occurred in the depletion group, underscoring a clear safety advantage for T-reg-focused therapies. The authors acknowledge several limitations. First, the included trials varied widely in patient age, disease duration, and follow-up length, contributing to statistical heterogeneity. Second, most studies used C-peptide as a surrogate marker rather than hard clinical outcomes. Finally, aggressive insulin titration in both arms may have obscured any true glycemic advantage of the immunotherapies. Future trials should incorporate continuous glucose monitoring to capture real-world glycemic variability, extend follow-up beyond 2 years to evaluate the durability of beta cell preservation, and explore combination approaches that pair immunomodulation with agents targeting metabolic pathways, especially given the IL-2 paradox. In practice, clinicians can expect a small protective effect on beta cells from current immunotherapies, but should not anticipate meaningful improvements in blood sugar. Low-dose IL-2 may be useful for glycemic control, though its impact on beta cell function is minimal. When considering immunomodulatory treatment, focus on patients who value even a slight preservation of endogenous insulin production, such as those at risk for severe hypoglycemia. Use HbA1c trends cautiously, as they may not reflect the true effect of the therapy. Given the higher rate of serious adverse events with whole blood cell clearance approaches, clinicians should favor T-reg enhancement strategies like low-dose IL-2 when safety is a primary concern. Vigilant monitoring remains essential for any immunomodulatory regimen. We thank Shankar Biswas, Bhavya Dhir, Susmitha Talasila, and their co-authors for conducting this comprehensive analysis, and we appreciate BMC Endocrine Disorders for publishing their work. Thank you for joining this deep dive into immunotherapy for type 1 diabetes. Keep following for future videos that translate the latest research into practical insights.